Before I start, I greatly appreciate you for giving me an opportunity to speak here. Okay, so today, this is my COI disclosure. Today, I'd like to introduce our updated data on clinical research in patients with community-acquired pneumonia. So our data includes both COVID-19 and non-COVID-19 CAP patients. So I'd like to talk about known and unknown things as an introduction. Then I will introduce our recent data on prospective observational multi-center study named the J-Captain study. Okay, let's move on to the introduction. As you know, in the past 3 years, many research groups have focused on COVID-19. Based on cumulative evidence on COVID-19, the treatment strategy for COVID-19 has been developed. However, there are many research on COVID-19 in the past 3 years. Evidence on non-COVID-19 community-acquired pneumonia is very limited. Now, the whole picture of CAP is unclear. So this is a Japanese situation. So COVID-19 pandemic brings many changes in society. So in Japan, most of Japanese are wearing masks in the public space. So even the Japanese government decided to defer people's discretion from this month, but many people still continue to wear masks. But today I don't, because all of you don't. Okay, so this is a flowchart of practice for CAP. In Japan, maybe similar to other countries, before determining treatment of CAP patients, the step to differentiate treatable viral CAP, including COVID-19 and flu, is included in the practice for CAP. Important clinical topics in the practice on pneumonia includes these 6 things: diagnostic testing on microbes, site of care decisions, initial empirical therapy, adjunctive therapy, approach for non-responding pneumonia, and prevention of pneumonia. So one big question is, can we consider these things in a similar way that was established before the COVID-19 pandemic? So we need to know, answer these questions. We need to know distribution of identified pathogen in patients with community-acquired pneumonia, including both COVID-19 and non-COVID-19, differences in outcomes between COVID-19 and non-COVID-19, and risk factors of antibiotic resistance in non-COVID-19 CAP patients to achieve appropriate initial antibiotic treatment. So we performed prospective observational study in multi-centers. Today, I will introduce a part of data of interim analysis of our recent study. The study name is J-Captain study. So I will shortly introduce a study design. This is a schema of the study. So in our university, in Nagoya University hospitals, we are collecting data from all kinds of pneumonia patients, but city hospital has difficulty to collect data from patients with nosocomial pneumonia. So in the multi-center study, we collected data from patients with CAP from these institutions. The study was performed these 14 institutions prospectively, and the patient enrollment period from November 2020 and November 2021. This is the criteria for patient enrollment. So this is inclusion criteria. General definition of pneumonia was adopted. Then exclusion criteria is shown in this slide. All patients who need, I'm sorry. Oops. Oh, thank you. Oh. What's that? Okay, look at this. Okay. Oh, this is inclusion criteria. So in our study, all patients who need inpatient treatment were included. Oh, okay. So in our study, we set several clinical and microbiological endpoints. Those include death, types of unidentified pathogens, and drug resistance of identified bacteria, severe adverse events, and secondary adverse events, and early and late treatment failure. In this presentation, I will focus on the second endpoint, types of unidentified pathogen and drug resistance of identified bacteria. Okay, I'll show you the result. In this study, the number of eligible patients with community-acquired pneumonia was 3,319. Among them, 1,803 were non-COVID-19 and 1,516 were COVID-19. This chart shows the trend of number of patients. In Japan, there was 3 waves of COVID-19 during the study period. On the other hand, look at the right side, the number of patients with non-COVID-19 community-acquired pneumonia was decreased with years, but the number of patients seemed not to be affected by COVID-19 wave. I will summarize baseline characteristics very shortly. Oh, we can see this one. Okay. So regarding age, age was higher in non-COVID-19 groups and younger in COVID-19 groups. And the BMI was higher in COVID-19, but lower in non-COVID-19. Many ambulatory patients were included in non-COVID-19 groups. So many comorbidities and abnormal values of vital signs were seen in non-COVID-19 groups. However, the frequency of diabetes, I think, the frequency of diabetes was very similar between the two groups. This is the baseline characteristics. Regarding laboratory findings, high CRP value was seen in non-COVID-19, and frequency of severe respiratory failure was very similar between the two groups. And in non-COVID-19 patients seem to be classified into severe groups compared to COVID-19. This chart shows the age distribution according to type of pneumonia. So this in our data, patient with Omicron variant was not included in our data. So mean age was younger in COVID-19, but the non-COVID-19 patients was they are older than COVID-19. Okay. This chart shows the number of patients according to age. So the interesting data here is right side chart shows the data obtained 10 years before. So as you can see, left side data shows current data. As you can see, there was not small peak around the younger age in the current data. I think this may reflect the number of patients with atypical pneumonia, including mycoplasma, was decreased. Okay. This table was this table was published in the Dr. Thomas Farr's review, and regarding causative pathogens in CAP, many previous research, including our research, have revealed that major causative pathogens include pneumococcus, Haemophilus influenza, and mycoplasma. But now we have a question. Can this knowledge be applied in the clinical setting now? So this is the most important slide in this presentation. So in our updated data, here is the right side is non-COVID-19 and COVID-19 and non-COVID-19. Please look at the non-COVID-19 patient data. So the major pathogens, the most causative pathogen was Staphylococcus aureus, followed by Klebsiella pneumonia, then pneumococcus. The frequency of pneumococcus was similar to that of Pseudomonas. This is the current data. However, the frequency of potentially drug-resistant pathogens such as Pseudomonas and MRSA was not increased in the 10 years. This table shows changes in the distribution of identified pathogens. So between recent data and the data obtained 10 years before. So as you can see, the frequency of pneumococcus and Haemophilus influenza were significantly decreased in these 10 years. Compared to data obtained 10 years before, these proportions were significantly decreased. However, the frequency of DRPs was not increased. Okay, this is the data on outcomes. 30-day mortality in non-COVID-19 patients was 11% and 4.5% in COVID-19. Severe adverse events were seen more frequently in COVID-19 group. However, the reason why the 30-day mortality was lower in COVID-19 was many patients who received mechanical ventilation survived. So we have a unique data on secondary adverse events, such as secondary infections and cardiac events. You can see the frequency of secondary infection in COVID-19 group is higher than in non-COVID-19 groups. That may reflect that more patients with COVID-19 received corticosteroid and other immunosuppressive agents. Okay, let's go back to this slide. So we understand the distribution of identified pathogens was changed. The next question is, should we change the strategy when determining initial empirical antibiotics? So we performed the analysis of risk factor for drug-resistant pathogen. Here is the result. When the analysis was performed among culture positive and culture negative cases, the significant risk factors include prior drug-resistant patients' histories, chronic lung diseases, tube feeding, and consciousness disturbance. And prior use of antibiotics was close to be very significant. This table shows data from only culture positive cases. You can see the significant risk factors for drug-resistant pathogen is almost identical data from culture positive and culture negative cases. Okay, let's move on to the last sections. Regarding distribution of identified pathogens, the distribution in CAP during the COVID-19 pandemic was different from the pattern before the COVID-19 pandemic. The proportion of pneumococcus and Haemophilus influenza were decreased. Mycoplasma pneumonia was not identified. The reason why is these findings are associated with the effect of mask wearing in Japanese situations. This contributes to prevent droplet infections. Actually, in fact, in Japan, the incidence trend of infectious diseases in Japan is like that. For example, influenza, varicella. So the dotted line during the COVID-19 pandemic is here and here. So the incident rate was very low. For example, on Mycoplasma pneumonia, chlamydia pneumonia, the data is very similar to influenza and varicella. So regarding the data on invasive pneumococcus diseases, the incidence trend of these diseases has decreased during the COVID-19 pandemic. So our findings may reflect the epidemiology of CAP in situations that the society has a strong strategy to prevent infection transmissions. We have a question. Does the trend go back to the previous days from now? We don't have the answer. Continuous survey is important. Regarding the risk factor for drug-resistant pathogens in non-COVID-19 community-acquired pneumonia, we showed this data. So significant risk factors for drug-resistant pathogens are not so different from those reported previously. So if you have a question, should we change the strategy when determining initial antibiotic treatment? The findings based on our findings said maybe no. The answer is no. However, our group is trying to assess risk factor for antibiotic resistance according to antibiotic susceptibility test results. We will report these results in near future. Okay, I thank all of my colleagues. This concludes my presentation. Thank you for your kind attention.
Very good. You see that Yuichiro asked his own question and he answered the question. Then we can go. That's very good. Yes, Tom.
Oh, okay. Well, thank you. Well, thank you very much, Dr. Shindo. I appreciated that presentation very much. I have two questions and maybe a comment. I mean, regarding the change in the pneumococcal positivity, were you able to correlate that at all? Or let me just ask, what percentage of adults in Japan received the pneumococcal vaccine?
Okay, so we have data, but I couldn't explain. Oh, let's go back to my slide. So vaccination rate among these patients.
Oh, I'm sorry, I missed it if you showed that. But.
Yes, I'm sorry.
Can we go back to the slide? We'll try to, but
Oh, history of vaccination. I see it. Okay.
So among people, the vaccination rate in Japan is currently about 30%. But patients with
it's change in behavior. So people feel free from all these COVID restrictions. They are more intensive together. There's more connections, which brings bacteria from one to each other, and this increases incidence. And one point for Germany, I can say it is very disappointing. That is the loss of vaccination rate, because of the disappointments with the corona vaccine, which did not protect for infection. No one who is coming from vaccination had expected this, but in the political arena, it was mentioned. And this disappointment now is transferred into a very low vaccination rate, either for flu and for pneumococcal disease. And this is something we have to work on, because that's a real problem.
Yes, Charles.
Yeah, thank you for your talk. You showed that in the non-COVID pneumonia, in terms of the organisms that were represented compared to COVID, a lot of them were decreased, right? Any of them increased? Because I was wondering, is it just, is there a group of patients that you couldn't identify or bacterial infection?
Yes, so our data shows due to the fact that most of people wear masks, the droplet infection was prevented. As a result, the proportion of pneumococcus and H. influenza and mycoplasma was decreased. However, maybe related to the comment by Tobias, aspiration pneumonia was not decreased. So Klebsiella and other type of Enterobacteriaceae was not decreased in this study.
This is a very interesting topic. What happened with the epidemiology of pneumonia during COVID and after COVID, and what is going to happen after COVID? I mean, you mentioned masks. Tobias also explained that now we are together. But it's also interesting to see, I mean, we still don't have an explanation why when COVID arrived, RSV influenza disappeared. All the other viruses magically disappeared. And now COVID is coming back, and these viruses, I mean, Rosario has, you see Rosario, they're coming with a bench. They're coming out. The influenza RSV, after being who knows where, they are coming and they have all these co-infections. I mean, this is. Yes. Yes. Yeah. But it's going to be interesting, the epidemiology and the virulence and the associated, what is going to happen. Okay, this is excellent. Well, thank you very much.